Welcome to episode 31 of the Fire Rescue Wellness Podcast. And today I sat down with my friend Rachele Burriesci and we talked about all things COVID and long COVID. Rachele is a physical therapist who specializes in cardiopulm. I didn't even know that was a thing, but she is one of a very few of these specialists out there. And so give it a listen. And if you enjoy the podcast, share it with someone you think would also enjoy it. Thank you for joining me on the Fire Rescue Wellness Podcast. I'm your host, AZ. I find the research and resources and then provide the fire service with the so what, now what, to ensure the health and well-being of every member of our profession. Together, let's thrive. Hello, everyone, and happy Valentine's Day. It is my favorite holiday. I don't want to go into it. I don't need to justify it. It is my favorite holiday, but it is only fitting that today on the podcast, we have my friend, Rachele Burriesci, who is a cardiopulmonary physical therapist. I didn't even know that existed. So I'm going to start with the lightning round questions and then we'll figure everything else out from there. So, are you ready, my friend?
I think so.
All right. I didn't give you a chance. Say hi to the podcast people.
Hi, AZ's podcast people.
I love it. I love it. I love it. All right. Who is Rachele B?
Oh man, Rachele B, that's a loaded question. I am a New Yorker born and raised, been a PT for 13 years. I'm a cardiopulm specialist and geriatric specialist. I'm dual certified. I'm a dog mom, and I am now residing in the Midwest, taking it by storm.
All right. We're going to get back to the dog later because Remy's got the cutest little, wiggly butt. It's so cute.
Yeah, she does.
All right, Rachele, what sets your soul on fire?
I think this is an easy one. Learning and teaching. I will be a forever life learner. There is no part of me that will ever stop learning. I thoroughly believe that when you think you know everything, it's time to move on. And the only thing that makes me more excited than learning is teaching what I know, the how, the why do you care?
Oh, that's what I do here. Yeah. Teaching people the so what, now what.
Yep.
This is going to be a good conversation. All right, third rapid fire question. How are you changing the world?
Well, I'm hoping to be maximizing function and wellness in cardiac and pulmonary diagnoses, including COVID and long COVID, one clinician and patient at a time.
That's amazing. Now, I usually try to provide a little bit of a backstory about how I know my guest. And this is a funny one. So Rachele and I are members of something called the Mafia. Not the kind of mafia you're thinking of, like Rachele didn't bring it from New York. It's our friend Shantae. If you listen to episode 19, it is the Movement Maestro Mafia. And one day we were having one of our mafia dinners and Rachele said something about auscultation or something that just, it gave me pause. And so I direct messaged her in the chat and I said, "Lady, what do you do?" And she said, "I am a cardiopulm PT." And I said, "I have no idea what that is. Tell me more." So I want you to tell my listeners more. What does that mean?
Oh, okay. So I'm a physical therapist, and in the world of physical therapy, you can become specialized in a certain area. So most people, when they think of PT, they think of orthopedics, musculoskeletal system. The orthopedic section is probably the biggest specialty area in PT. I think there's over 20,000 OCSs. Neuro is another one, right? Patients post-stroke, any sort of neurologic impairment. There's an NCS, so there's a neurospecialty. There's geriatrics, women's health. There's also cardiopulmonary. So cardiopulmonary is actually the oldest specialty in PT, but is actually still one of the smallest. So I believe there's 400 of us, maybe 422. I haven't checked the most updated stats on it, but we're talking lower numbers compared to 20,000. And so what does a cardiopulm PT do? We're typically seeing patients that have specific cardiac and lung diseases like heart disease, patients post-MI, patients post-open heart surgery, patients with valve problems, patients with arrhythmias, patients who have emphysema and chronic bronchitis and bronchiectasis and asthma. And, the list goes on and on. And so what the specialty is really doing is being an expert at assessing those processes and then helping maximize that patient to better their current situation, right? Because most of these things you can't undo. Most of the lung diseases are irreversible. So if you can't fix it, how do you make it better? And you make it better with efficiency and breathing exercises and aerobic training and all that good stuff, but it's not common knowledge. So that's where we come in.
And I find it so interesting, your Instagram account, because so many of the things that you talk about are little snippets of things that we learned about in paramedic school. Mm-hmm. For example, recently you explained left-sided heart failure versus right-sided heart failure in less than 60 seconds. Now, I'm not going to put you on the spot, but I am going to link that Instagram post because it was so good. And she was speaking at about 486 miles per hour. So just for fun later, a friend and I asked her to say polycyclic aromatic hydrocarbons 5 times fast. Listeners, she crushed it. So one of the reasons that we're here today, in addition to the fact that she's such an expert in so many of the things that we dabble in paramedicine, is that our mutual friend, Bernie, is really interested in COVID and especially long COVID. And so let's just start from the basics. This was a novel virus. Mm-hmm. Our bodies didn't know what to do with it, mm-hmm. but most people recovered relatively well. Mm-hmm. Would you agree?
Yes.
Okay. But there's this subpopulation that's experiencing long COVID or long haulers. So first of all, explain to what does that even mean?
Yeah, so there's a whole bunch of definitions, and if I actually have a running document at this point for the definitions on acute COVID versus post-COVID versus long COVID, post-acute sequelae COVID. I mean, the words and the names addressing this situation is a little out of control, and I think is going to be problematic when we look at research. But essentially, you get infected with acute COVID. You breathe in an aerosolized respiratory droplet. It typically connects in the lungs, and the big problem with COVID is that it's attacking the ACE2 receptor. And the reason why I'm bringing that up is because COVID is basically, it always feels like a moving target. It really does. When you think about even just the list of symptoms that we give people before they walk into a doctor's office or whatever, right? You go from headache to brain fog to shortness of breath to fever to diarrhea. I mean, that's head to toe. And so it sounds like, why? Like, it sounds crazy, right? It's all over the place. But it's, when you look at the science of it, ACE2 receptors are expressed or exist throughout the body. It exists in the brain, in the heart, the lungs, the GI system, so on and so forth. So when that respiratory droplet attaches to the ACE2 receptor, it creates 2 big problems. The first is destruction, wherever it exists, and the second is inflammation. So that's the acute side of it. And that's why people have this random myriad of symptoms. The long COVID piece is interesting because it can present itself a number of different ways. One, you can have acute COVID, and those symptoms can persist. And so they can persist for greater than 4 weeks. And so they typically call that actually they don't call that one post-COVID, they call that ongoing symptomatic COVID. So it's greater than 4 weeks, it's ongoing, it's continuous. Then it goes into greater than 12 weeks, and they call that post-COVID syndrome. Same as long COVID, it covers both of those. But some people have this diagnosis, they get COVID, it could be mild, it could be asymptomatic, and then weeks, months later, they start presenting with symptoms. So long COVID has two pieces. One, it's either persisting from that initial diagnosis and it continues for prolonged periods of time, or you have COVID, you kind of recover, and then it comes back in this strange sort of way.
So this is already even more complicated than I even expected.
Yeah.
So let me ask you this, and maybe it's unclear at this point, but it's interacting with the ACE receptors, which are present in different parts of the body. Why do some people have some symptoms, and is that just all unclear at this point?
That's still unclear. So what is clear is that we have ACE2 receptors systemically throughout the body. What is unclear is why you might have more GI symptoms and I might have more lung symptoms. I mean, there are hypotheses out there. I have my own set of hypotheses, but there's no definitive answer to that question. So how you present is kind of like Russian roulette.
Oh, that's
You don't
funny.
know. You don't know. And you also don't know about long COVID. Like once you get COVID, you don't know if you're going to get long COVID. So that's part of the next piece.
How wonderful.
Yeah, it's a good time. It's been a good time for the last 3 years.
Yes, absolutely. Well, I'm just going to then say, tell me more.
Okay.
You have a lot more to share, so let's dig into it.
Okay, so I think I'm going to bring up one piece that still relates to the acute part because I think it's important, and that's the inflammatory piece. So I said there's two big issues with COVID. The first is that we have this connection to the ACE2 receptor. Think of it like lock and key. The COVID spike protein matches that ACE2 receptor. It fits it, so then it causes destruction wherever that is. The second part is that we have this, and many people have an exaggerated inflammatory response. So we know that when we get sick, there's an immune response that's supposed to happen. With some people, it is exaggerated, and you may have heard the words cytokine storm. Mm-hmm. So part of this whole problem with COVID is that we have literal destruction in certain areas of cells. And then the second is that we have this persistent, exaggerated inflammatory piece that lingers. And when inflammation lingers, it causes issues.
Would people that are generally more inflamed in the first place then experience greater inflammatory response during COVID, or is it unrelated?
I think it's unknown. That is part of my hypothesis, that if you already have an inflammatory component, that you are going to be more likely to have an exaggerated response. It's the same kind of concept with autoimmune. The research doesn't really show that people with autoimmune disease are more likely to have an exaggerated response, but that COVID causes an autoimmune-like response, if that makes sense.
Absolutely. And those autoimmune responses, at least in my little brain, are almost more scary than just the regular immune response. Holy
Absolutely,
moly.
because you're fighting yourself. So your body's fighting its own immune system, which causes its own set of symptoms.
Yikes. Okay, so now we are 12 or 16 weeks into it and experiencing varied and unknown symptoms. Now what?
So if you're still experiencing symptoms past 4 weeks, you're considered entering that post-acute world, that long COVID world. And so the question is, what are you doing to address this? So unless you're hospitalized from COVID or are able to get something like Paxlovid, which still has, not great support behind it, there's really nothing that happens, right? You get COVID and then you kind of write it out because it's a virus. There's no true medication that's treating it yet. So what do you do? So I personally think that there are 3 main pillars to treatment, maybe even say 4. The first is we have to get rid of the inflammation. So I started diving into lymph drainage. We need to be affecting the vagus nerve, so different techniques to basically tap into that nervous system. We need breathing exercises, and we need to be able to do targeted aerobic exercise or gradual progressive exercise to get you back to your base and even to get you back to work, higher level type work, firefighters, paramedics, people who are in, like, physical therapists, right? I work in the hospital. So can we return to work safely? So being able to gradually get there.
So what do you think about breaking down these 3 or 4 pillars one by one?
Sure.
Should we do it? Okay.
Let's do it. So the inflammation's a big piece of this, right? And so we think the inflammatory response is kind of what's the culprit behind the long COVID symptoms. So in long COVID, you're going to see things like extreme fatigue. That's probably the most common. You hear a lot about brain fog. You hear a lot about exertional fatigue or post-exertional fatigue. A lot of sleep disturbance, muscle joint pain, and then there's a whole bunch of other stuff. Oh, POTS, that's a big one. So I'll keep POTS on the back burner because that kind of fits the vagal nerve stuff.
So let me ask you about this joint pain, asking for a friend. Is it usually a particular joint, multi-joints, or a moving target?
Same answer that I have as before. I don't have that answer. I have a hypothesis, and that is if you've had knee pain, back pain in your past, it is more likely to have that sort of pain. Is that for fact? No, it's anecdotal. But it's kind of like when you have the flu or when you have acute COVID and you have joint pain, like it's deep and it's achy and annoying. So everyone's different. Moving target. Don't have a direct answer for that, but my hypothesis is if you have, for instance, arthritis in your knees or your back, you might be more likely to have pain at those joints compared to others.
Interesting.
So what I tell anytime I'm teaching about COVID, long COVID, this disease process was novel. We use the term unprecedented quite a bit. But I like to remind healthcare professionals or whoever's dealing with and treating with this population is that we don't have to reinvent the wheel. We need to use the knowledge that we have dealing with other diagnoses and bring it here. So the 2 big things that we were seeing was this breakdown in certain areas. And so one of my breathing exercises is very specific to that. And the other is this inflammatory piece, right? Like this inflammation seems to be the culprit. Brain fog is inflammation. Like there has to be. Loss of taste and smell. Lots of possible causes for that. Is it destruction at the nerve itself? Is it inflammation of the brain that senses that sort of like loss in taste and smell in the brain perception? Lots of possibilities, but it kept coming back to inflammation. So lymph drainage is not my normal realm. But because I was breaking this down and I kept seeing inflammation, I kept asking, how do we deal with inflammation? So you can deal with inflammation a number of ways. Lymph drainage was particularly kind of stuck out to me because it's the waste system, right? So if we have these stuck points in our waste system, then it's going to cause issues. So lymph drainage is my one piece of this. And I will tell you, when people are in the acute phase, it's the first thing I tell them to do. It's gentle rubbing in specific spots related to the lymph system. And the idea is that you're clearing the pipes. You're clearing the sewage. You're clearing it out so that we can keep replenishing and basically help alleviate some of that inflammation. So there's a whole head and neck routine. There's a full body routine. And people really do, especially if they have high congestion, brain fog, feel very different as soon as they're finished performing it. So that's been one big piece. The other thing that's happening with long COVID is the heart rate response. So I don't know if you know anyone who has had COVID. The return to high-level activity is difficult because the resting heart rate is high. So again, there's a number of possible hypotheses as to why, but the vagus nerve is starting to get a little bit more press these days. And essentially, if you're thinking about the nervous system, you have two sides of your nervous system that help with heart rate, blood pressure response. You have sympathetic and parasympathetic. So your sympathetic is your fight or flight. It's going to get your heart rate, blood pressure going up. And your parasympathetic is known as your rest and digest. But it's more than that. It's your base. So your resting heart rate is set by your parasympathetic system. It also is what helps you come back down off of exercise. So when you're recovering during exercise, it's your parasympathetic system kind of driving that. So why is it happening? Not sure. Again, could come right back to that inflammation of the vagus nerve. It could be higher in the brainstem. Either way, we have to try to attack that. So learning different things like vagal nerve techniques, trying different things like taping. You can activate vagus just by humming and singing the vibration, right? So there's a number of like very low-key things that you can do. There are specific spots you can rub on your face and neck. There are tape spots that you can use. So just diving into the neuro side was different for me, or, taking the cobwebs out. But as a human, you're not just a cardiopulm system, right? You're not just a neuro system. Everything works together at all times. And sometimes you have to step back outside of your specialty and look at the whole picture and connect the dots.
And you're on a roll, and I hate to interrupt you, but I'm gonna.
Hold on.
The vagus nerve keeps coming up in terms of trauma, too.
Yes.
And so, and maybe you don't even want to speculate, but I just have the question. I wonder if people in jobs like first responders who already might have vagus nerve disruptions might then experience the symptoms of COVID in an amplified way.
100%. I think it's a hypothesis. I don't think it is stated anywhere for fact yet, but I don't think we can say anything is fact yet, right? Like we're learning as we're going. But a known risk factor at this point for long COVID is PTSD, stress, anxiety, depression. So you can look at that from a number of different ways, right? Is it the COVID itself causing the PTSD, the stress, the anxiety? I mean, of course it is, right? You're maybe out of work for weeks, or you can't perform at your optimal. There's so many reasons. There's the stress of, am I going to get long COVID even if you don't have it? Like, there's so many pieces to it. Or does your past history of PTSD, anxiety, depression put you at a higher risk for said things? I don't know. Could be both.
More to come.
More to come.
All right. I want to keep you marching on your pillars because these are fantastic.
We're on vagus, right? So
when
you tap into vagus, you can help calm the parasympathetic system, or tap into the parasympathetic system, I should say. So if you're starting at a high heart rate, right, you're resting in the 90s, you're resting in the low 100s, you don't have a lot of room to play for activity. And so that's a piece of not being able to get back to your prior level of activity, because your room to hit your range is now decreased, as well as your response to come down from it. So tapping into vagus has been helpful in helping bring down that resting heart rate. And then breathing is breathing, right? There's just so much benefit to breathing. I have my own personal things that I do, but I'm starting to dabble in things that people who study yoga and more Eastern medicine type stuff, because it's just how you tap into the system. So is there one right way to breathe? Absolutely not. If anyone tells you that, that is absolutely false. But from a breathing perspective, if we're talking about like COVID from the beginning, it attacks the lungs. And when it attacks the lungs, it attacks a specific part of the lungs initially. So I'm going to use a fancy word, alveoli.
Ooh, my favorite. It's those little pieces of pasta with the meatballs on it, right? Okay, just kidding. Continue.
Sounds like it. Sounds like it. It's the part of the lung where gas exchange occurs. So they call it the functional unit of the lung. I like to say it's kind of like, have you ever been on a train and you're at the last train station where it's at the last stop? Everyone gets off and everyone gets on. So after all the tubes of breathing, bronchioles, all that stuff, you get to the alveoli. And that's where the magic happens. Oxygen goes in, CO2 comes out. If we have destruction there, it leaves them open to leakage, which causes fluid to surround the alveoli and in some cases even get in, which makes gas exchange really hard, which is why that first wave of COVID hit oxygen pretty aggressively. People were being mechanically vented, proning, you've heard all those words. It really hit that structure hard. So even through some of the variants, it's still hitting that, just not as aggressively. So my go-to breathing exercise is called an inspiratory hold, and its role is to basically hit that alveoli. So the concept is if I breathe air in and I hold my breath, it's going to pop open those alveoli and push air into the alveoli, even if it's blocked, because there's like little mini passageways. So the hold creates a pressure to basically push the air to the spot that needs it. And then exhale. So I usually do a 2-second inhale, 2-second hold, 4 seconds out. But it's really dependent per person, so I don't want to make that a blanket statement either.
But the idea is there is that hold that helps pop them open. Okay.
Right. Or push air in, whatever is the problem at the alveoli. Yep. Whew. I know, it's a lot of stuff, right?
And it's a little bit overwhelming. It's frightening. And that whole unknown factor is... Ugh. All right. So then you mentioned targeted aerobic exercise. Tell me a lot about that. A lot.
Okay, sure, will do. There's not that much, though.
Oh.
I think this is the easy part. I'm like, I'll tell you everything I know. The breathing, the lymph, and the vagus has to be a steady. Sorry, I use my hands quite a bit. I'm Italian. It's just like knocked to the microphone. Is a steady process, and I will tell you that most of my clients who are long COVID, it's like an everyday thing. It's like their hygiene for the day. So that has to be base. And I will tell you that when people back off, symptoms do arise, at least in a small number of people that are under my education, knowledge, whatever we want to call it. But the big thing is, how do you get back, right? So especially in first responders, that's a stressful job. It is a high level of activity between your equipment and the aerobic capacity that you have to maintain. I know you talk about VO2 max quite a bit. You have to be able to perform, right? You can't go into a situation not ready. So how do you get there? Well, one, I would say don't expect to get there immediately. This is a long and slow game. And I'm like over cautious, over conservative with this type of thing because there is the unknown. Because you don't know how you're going to respond, it's not worth taking the risk to go hard and fast and then have to play the backup game. So in that first acute time, let's say 3 to 4 weeks, I usually encourage low intensity. So we're talking 40 to 60% of your max heart rate. Some people are resting in that zone. So if you're resting way above your normal resting level, you can't expect to be doing high-level aerobic activity. And I honestly do not recommend it because the constant thing I hear from my clients, my patients, is I felt good, so I tried this thing, and now I'm down for 2-3 days. So my education is very annoying because it's slow It's a gradual progression, and it's a wait and see. So you do it, you did fine, you're not down, okay, great. We can either maintain at that spot or up it a little. Maintain at that spot, up it a little. But you don't know until it happens, with the constant lymph vagus breathing in the back burner, because that's the stay.
So, but really, if we just back it up to musculoskeletal, kind of the same thing. We give the dosage and see how we respond.
Correct.
And either hold it there, come back, progress it, exactly the same thing.
Right.
We just need to think differently.
Right. And you have to think you're not going to be the same that you were prior to that diagnosis in that moment. And you have to work up to it. Somewhere around 4 weeks, it really depends on the person. I don't even want to put it black and white, but let's just say that 3 to 4 week mark, pending how you're doing, then we start to move into the 60 to 80% of max heart rate. And I'll tell you, people will say, if I try to go above this number that you're telling me, I feel like I have to quit.
Wow.
And it makes sense, right? Because you don't have as much room to move. So we have this overreaching heart rate with exercise, even submax activity, we're going higher than what we did before. You're going to hit that top much faster. So you have to slow and steady get back there. And every time you add something, wait and see. Because you honestly don't know. Everyone's trial and error. That's really how I approach it.
So we have to play the long game. I hate the long game.
The long game is hard in this one because it's unpredictable, right? Some people can go back and they're like, yeah, I feel fine. Nothing's happening. Great. Some people try to go back, and as soon as they do too much, too fast, they're down 2-3 days, and in some cases, weeks. So it really just depends on how gradual, how purposeful you're being in that return. And I would say, especially in a career where you are in high level of activity, you need to be cautious about that. Because what happens if you're not ready? So I'll speak personally. I got COVID this past September. I made it 3 years. I was convinced I was going to make it through this thing without getting it, and I got it. And now I have a history of POTS. I have a history of asthma, and I was worried that it was going to re-trigger my POTS. My resting heart rate was super high. My sleep was awful. I was waking up with what felt like an arrhythmia in the middle of the night. And I had to go to work, right? Because you get cleared in however many days. And I was like, I can't do this. I cannot treat a patient, transfer a patient, knowing my heart rate is out of control and I feel like crap, right? I'm fatigued. I do too much too fast. I could be down for weeks. So I took the week, 10 days before I went back, because I knew it wasn't going to be pretty. Or scary, right? Because you don't want to be in a situation where you're passing out in a patient's room. Like that's not in my good
That's not
days.
your playbook.
It's not my playbook.
Rachel, tell me, I feel like I should know what POTS is, but it's not clicking.
That's okay. POTS is actually not that well known. It's actually hit more recently with COVID, it's becoming more spoken about. So POTS is postural orthostatic tachycardia. It is defined by an increase in heart rate of greater than 30 beats per minute with a change in position of supine to stand. So laying down to standing.
Got it.
It's very specific that within 10 minutes of standing, your heart rate increases 30 beats.
Wow.
So you typically feel syncopal, like you're lightheaded, dizzy, gonna pass out. You typically are fatigued. There's a slew of weird symptoms that come along with that.
And so some people have experienced these symptoms of POTS even before COVID?
Yes.
Is that a genetic thing?
Nope. Not that I'm aware of. POTS is a dysregulation of the autoimmune, I almost said the wrong word, autonomic nervous system. So something triggers this dysautonomia, this dysfunction in your autonomic system. Typically it can be stress or virus. I actually was diagnosed with POTS at the end of my residency for cardiopulm. So big stressful period. No one really knew. It took a while to get that diagnosis, but it was rapid heart rate shifts, dizziness, lightheadedness, all of that stuff. The thing is people with COVID and long COVID are presenting as POTS patients.
Wow. So we kind of laid out the 3 to 4 weeks, 40 to 60% max, slow and gradual, wait and see. At around 4 weeks, maybe working up to that 60 to 80% of max. When do we start trying to push it a little bit harder? Is it just a waiting game at that point?
It's just trial and error. Can you work at 80% and feel good? Right? There's no research on it yet, so I don't know what HITS training will look like in this patient population, but I don't think it's a good first step. Like, I think you're going to have to wait and see, trial, like low level hits, meaning like time, how many intervals you're doing, and then see what happens. But it just depends on your person. This is such a individualized progression that it's hard to make a blanket statement.
Yeah. Well, and the thing that just occurred to me is that much like a mental injury that we get in the fire service, some of these COVID, I'll call them injuries for lack of a better word, are also invisible.
Yes.
And also probably pretty hard to prove, so to speak. So if you are someone that is suffering from the symptoms of long COVID, or you were just listening to her talk and going, oh, check, 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 what would you say would be a good first or couple of first steps for these people who think they might be suffering from long COVID?
Find a provider that can help you. Be very clear about your symptoms. If you have a known diagnosis of COVID or likelihood that you've had COVID, that is a good first step, because there's a number of people that don't have an official PCR, there, especially early in the pandemic where there wasn't even enough testing, or you home tested, right? So there's lots of different things. If you think that you had COVID or you have this wild array of symptoms, find a provider, talk it through, potentially give the date of your COVID symptoms, and then hopefully find someone who can help.
And would that be one of those 400 cardiopulm PTs or just a medical doctor?
That's a good question. I can't blanket statement that. A medical doctor would be the first step, asking for a PT referral is possible, but not all PTs are doing, for instance, what I'm doing. So you need to find someone who is versed in lymph drainage, vagal taping, breathing, and then reach out.
I've had several PTs on my podcast who do remote physical therapy. Is that something that you also do? Or is this a treatment that you could get remotely?
Yes. Yes, it is.
So what I'm hearing is that you should be maybe reaching out to the good doctor here to get you some help.
Yeah. So we do coaching calls. I do coaching calls and help work through that system. I have to be honest. I keep trying to find other people in different areas that can do that. So if you want to go local and have different options, that's always the first recommendation. But it is not easy to find. So yes, I do virtual coaching in this realm.
Well, I always sort of wrap up the podcast with, is there something that I should have asked you, or, a rabbit hole that we didn't yet go down that we should travel down?
Yeah. I think we went down some good rabbit holes. I think we saw a pretty good picture of just COVID and long COVID overall. What I would say is low and slow. Do not try to barrel through this. It is a wait and see. So build yourself up, progress. Don't try to overdo it fast, because typically what happens is the backtrack is harder. The one piece I guess we didn't talk about is long COVID has a set of words attached to it now that's called relapsing remitting. And those are words that are typically designated to MS. And so that's the scare. I don't like to be fear-mongering, but that is the scary part, right? Because it's unknown, right? You can have good months and then something could trigger it and then you can have a relapse. So it has to at least be on your radar that if you had COVID, that you had long COVID, and you have some sort of stressor. The triggers for long COVID are stress and exercise. Those are like two big triggers. That's really, the world that we live in, the jobs that we do, stress is inevitable. And exercise is the one thing that's supposed to be helping, but can trigger if you go too hard, too fast. So I want it on your radar that if you have had COVID, that if you have some sort of episode, stress, maybe you try to do something too hard, too fast, like I'm going to go run a 10K today, and I didn't, train for that, and you all of a sudden have these symptoms and you're down and you feel fatigued and you feel crappy, keep this on your radar as this could have been a trigger.
And then is not running any 10Ks.
I am not either.
25-year-old Annette, yes. This Annette, no.
But low and slow. And the last thing is you're not crazy. I've heard so many patients say, I feel like no one's listening to me, no one understands what's happening to me. Basically, what I'm teaching clinicians is if it doesn't feel like it makes sense or it's all over the map, came out of nowhere, you should be asking as a clinician, have you had COVID? Did you have a PCR? Have you had lab work? So lab work would be the other piece of this too, but.
Wow. Well, since we're about to wrap up, I feel like this is a good time to ask you about Remy.
Remy!
Tell us about Remy.
Oh, Remy. Remy's almost 4. She's going to be 4 in May. I cannot believe it. She was a pre-COVID dog who, I swear, there's a book that I have not read yet. It's called Your Dog is Your Mirror. I'm pretty sure I have ruined Remy. So Remy is a rescue mix, is what we like to call her. She's a border collie, pit bull, dachshund. I don't know, she's got a whole bunch of different, she's got 6 things in her, but it's basically smart and stubborn and high energy.
That sounds like me.
Smart, stubborn, high energy, and at her 1-year birthday, it was like someone flipped a switch and she started having sound sensitivity anxiety. So like she stopped going on walks. She was very scared of garbage trucks, school buses, if we passed like a dumpster with construction. So we have been doing training with Remy since that time. So different environments, every meal is a training session. She actually trains more than I do. Twice a day, every day is our routine. And she's she's like my partner in crime. She's my employee here.
She's adorable. And she has her own Instagram account.
She does. From the business side of thing, I was told that I had to chill out on Raising Remy. So it's at Raising Remy KC _ between the 3. She is definitely Insta famous, or was. She's starting to lose followers because I'm not as active. And our big day of the week is Fancy Ear Friday.
Oh, yes. Yes, I do like the fancier Friday.
Yeah, we have theme days. She's a hot mess. I'm a hot mess. We're a wonderful pair.
No, she's adorable. I love her antics.
Yeah.
Well, since we know how to get a hold of Remy, we should probably know. I will put your email in the show notes if that's okay.
Yeah, it's
and your Instagram handle.
Yep.
But it is at all _things _cardiopulm, correct?
Yep.
And then what is the day of the week you do the explanation under 60 seconds?
It's this versus that. So I typically do it on Thursdays.
Okay.
Technically 90 seconds. It's not a lot of time.
Technically 90 seconds.
It's technically 90. I have 90 to say as much as I can in 90 seconds, and I do a comparison.
It's unbelievable. So you need to follow Rachel for this versus that, because it is.
If you want to hear a fast-talking New Yorker get big words out real quick, You'll hear
and
it.
talk with our hands.
And talk with my hands. I have to put my hands in my pocket so I won't hit the microphone again.
Well, Rachel, I am so grateful for you, and thank you so much. This has been very educational, and my listeners are going to love it. And so with that, AZ and Rachel are officially out.
Thank you, AZ.